It's dead quiet. Good evening, and welcome to the first PharmTalk community lecture hosted by the Arkin Coit College of Pharmacy. My name is Rick Schnellman, and I'm Dean of the college. Before we begin, I want to respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign native nations and indigenous communities through education, partnerships, and community service. Tonight's PharmTalk is an opportunity to learn about the breadth and depth of pharmacy profession and the impact our college on the broader community. Our college is ranked number 5 out of 142 colleges of pharmacy in this country. It is educating the next generation of clinical care experts, and our nationally renowned researchers are developing new therapies and standards of care. Whether you are a healthcare professional or simply interested in learning more about the field, I hope you will find today's series of talks both informative and engaging. And now I will introduce our first topic and speakers. First topic, and that is, pharmacists today work side by side with doctors, nurses, and healthcare team members. In this session called Perspectives on Modern Pharmacy Practice, Dr. Bernadette Cornelissen, I always have their name, Assistant Clinical Professor, and Dr. Christopher Edwards, Assistant Clinical Professor also. We'll explore innovative ways that pharmacists are using their knowledge and skills as the medication experts to help make our care of our patients and communities. Please join me.
All right. Thank you for the introduction, and thank you all for the warm welcome. We're excited to be here today to kick off the PharmTalk series, the first ever. We want to start with a couple of disclaimers, though. So the last thing we want to do is come in here and bore you all to sleep, right? So we wanted to make this an interactive discussion. So there will be opportunities for you guys to share your perspectives on pharmacy practice and what pharmacy means to you. So please take advantage of those opportunities. This will be a lot more engaging with your participation. The other disclaimer is that we prepared this for a general audience. So I know we've got some pharmacists in the room. We've got a lot of pharmacy students in the room. So some of this information may not be new to you, but we would encourage you to hold off on sharing your perspectives until some of the other folks have had a chance to speak up. And then particularly if we get crickets, please feel free to chime in, okay? All right, with that, let's go ahead and get started. So when you hear the word pharmacist, what comes to mind? Anybody? Pharmacist at CVS? Okay, very good. Prescriptions, excellent. Any other thoughts? Experts, ooh. You may have read the notes. Drug safety, good. Opioids, excellent. All right. Anything else? Yes? Scrutinized. Scrutinized by the law, meaning they have a lot of laws to follow and sort of pay attention to. Very good, a lot of regulations. Excellent. So you all hit the nail on the head. When I first got into pharmacy, that was my impression of pharmacists as well, right? My interactions with pharmacists had been at community pharmacies, while filling a prescription, maybe getting some help with over-the-counter medications. But today we're here to talk about all the different ways that pharmacists serve as medication experts.
Yes, thank you. Okay, so as mentioned by one of our guest speakers that'll be coming up soon, is we are the medication experts on the healthcare team, and that is our role on the team. So when we think of pharmacists as a pharmacy professional, we think of the medication expert. So community pharmacy, as you all mentioned, maybe some prescriptions come out of the community pharmacy, maybe you've engaged with your community pharmacist to ask for some kind of OTC therapy recommendation. A few other things that these community pharmacists do that are unique is maybe an immunization. Has anybody gotten an immunization from their pharmacy? Yeah, great. So the pharmacists and their team, they give immunizations. They were actually key to helping people get immunized during the pandemic, and then recently just with the flu season that had happened. Another thing our community pharmacists do, because they are one of the most accessible healthcare providers on the healthcare team, is they're able to do some smoking cessation with our patients. So patients that are wanting to quit, they can come to their community pharmacist, see that pharmacist, they can be assessed by the pharmacist, and the pharmacist can make recommendations and actually prescribe some nicotine replacement therapy for that patient so that they can quit smoking. Another sector of community pharmacy that's really neat is called specialty pharmacy. And I know we have one of our specialty pharmacy managers here in the crowd. And so these drugs with specialty pharmacy require a little bit more oversight than what you get in a community pharmacy. So in the community pharmacy, we're able to look at medications, make sure that they're safe, make sure that they're effective, and that they're cost-friendly for the patient. There are medications that are then in the hospital that are given that require maybe a higher level of a pharmacist that Dr. Edwards will be talking about. Specialty pharmacists kind of fit in between there. They're looking at medications that are maybe an injectable that requires monitoring of lab work for a patient, ensuring that the patient is able to take the medication on a scheduled basis and that they can, again, afford the medication. I think we're going to switch over now to the hospital side.
All right. So how many of you know that pharmacists work in the hospital? Show of hands. All right. We weren't sure what the crowd was going to look like here, so I'm glad to see lots of hands go up for that one. All right. So what do hospital pharmacists do? I'm a hospital pharmacist. Worked in a hospital pharmacy my whole career. What do you guys think I do? All right. Go ahead. Excellent. Yeah. Coordinate with doctors and other health professionals to coordinate treatments for patients. Good. Excellent. That's a very full and concise answer. Very good. Didn't leave a lot of room on that one. What else? What do we do besides working with other healthcare professionals? In the back.
Activate the crash cards.
Activate crash cards. Oh, man after my own heart. Excellent. What else? Special medications, yeah. So compounding, things like that. Good. Medication reconciliation, good. So making sure that we know what medications the patient was taking before they come into the hospital and that those medications get ordered and continued while the patient is in the hospital. Excellent. Anything else? Was it? Rounds, yes, rounding. All right. So when I think about hospital pharmacy, there are a lot of different aspects that hospital pharmacists get involved with. So you have the more traditional roles for hospital pharmacists. This would include things like compounding, including sterile compounding, right? Hospitalized patients require a lot of intensive therapies, and some of these medications are going to go intravenous. It's important to ensure that these medications have been made in a manner that's safe, that they're sterile, that they're at the right concentration. And while a lot of that work is done by pharmacy technicians, that sterile compounding process is overseen by pharmacists. So this is one of what I think of as the classic roles of a pharmacist in a hospital setting. Another thing that pharmacists do a lot of is order verification, right? So any medication that gets ordered for a patient in the hospital gets reviewed by a pharmacist, hopefully before the medication gets given to the patient. And during that process, the pharmacist is checking to make sure that the medication is appropriate for that patient, that it's dosed appropriately, that they are considering the patient's renal function, liver function, their weight, their age, all these different factors that might affect the dosing. They're also checking to make sure there aren't any drug-drug interactions and that we have the medication available. If any of those things don't line up, the pharmacist will make an adjustment in order to make sure that the meds we're using are safe and effective. But you guys touched on a lot of the more modern or more advanced things that pharmacists are doing. So I'm an emergency medicine pharmacist by training. My clinical practice site is in the emergency department. And what I do every day is work shoulder to shoulder with doctors, nurses, respiratory therapists, paramedics, pre-hospital providers in order to assess and optimize medication therapy for patients who are presenting to the emergency department. So when people come in and they're acutely ill, a lot of decisions need to be made very quickly. And so I work up those patients with the physicians and nurses, and we design the treatment plan right there in the room with the patient. I'm not the only one who does that, though, right? There's a lot of pharmacists running around in the hospital, and pharmacists are members of basically every care team you can imagine. So there's a pharmacist working with the ICU team, taking care of critically ill patients. There are pharmacists taking care of geriatric patients with the geriatrics team. There are pharmacists taking care of patients with infections with the infectious diseases team, toxicologists, basically every specialty that you can imagine, pediatrics, cancer, transplant. All of these teams have a pharmacist on there to serve as the medication expert in order to ensure that we're providing the best possible pharmaceutical care that we can for these patients.
Okay, so the show of hands seems to be working. So by a show of hands, how many of you knew that pharmacists can prescribe medications? Okay, some not. Great. So I'm going to kind of transition you from the inpatient world, where Dr. Edwards talked about what pharmacists do on the inpatient side or in the hospital, to the outpatient, so our ambulatory care clinics. So this is a clinic where you may go to get your annual wellness visit or just your annual visit with your provider. So pharmacists may be embedded in that clinic. If they're in that clinic, they work on what's called a collaborative practice. And so similar to kind of like a physician's assistant, they work under the doctor's license in order to see patients, and then they can prescribe medications for those patients. Some examples of these chronic conditions or disease states that the pharmacist manages is listed on this slide. So if you know someone, and you feel comfortable raising your hand, that has any one of these, diabetes, high cholesterol, high blood pressure, maybe asthma, or they smoke, why don't you raise your hand? Yeah, all of us, right? Majority of us, great. Yeah. So these are the common chronic conditions that pharmacists can manage within the clinic. So I work in a family medicine clinic, and what happens is whenever a provider is seeing a patient and they're unable to control, say, their blood sugars, then they send a referral to me as the clinic pharmacist. And then that patient's going to come to me, and I'm going to work with them on their diagnoses to determine what medication plan is going to be best for them. So again, just what Dr. Edwards talked about, we want to make sure that it is the safest regimen for them, that it's going to be effective, and that it's cost effective for the patient, utilizing everything about that patient. The patient that is in the bottom, what is that? Your right-hand corner with the medications kind of coming out of the head, that represents polypharmacy for me. So polypharmacy is another we call it disease state, or another thing that can be referred to the pharmacist in the clinic. Polypharmacy is just any medication that a patient is on that they shouldn't be on anymore. Maybe it's not necessary. And my claim to fame on this is looking at a patient that had 53 medications, and they were referred to me. This patient was taking it every day, right on time, and some of the medications were no longer needed. So over time, we worked with this patient, and we were able to get it down to about 30 medications, and we're still working with the patient to continue down that path. I know there's some pharmacists in here. They may have actually trumped me on the 52 medications for polypharmacy. All right. So that kind of leads us to the future of pharmacy. You all seem to have a great background of what pharmacy is based off of your answers to our questions. So what does the future of pharmacy look like to Dr. Edwards and myself? Is basically having a physician or a doctor diagnose that patient, where you go and you see your doctor and they say, you know what, you have X, Y, and Z going on. They write that down, That comes to us, the pharmacist, the medication expert, and we assess the patient for the medication therapy that's going to be best for them. And then we would prescribe that medication for the patient and then help manage their disease state as a team from there on out.
So at this point, you might be asking yourself, how does one become a medication expert, right? What does the training of a pharmacist look like? It typically begins in undergrad. So there is a set of prerequisite requirements for admission to pharmacy school. These can be completed in as little as 2 years if a student is really aggressive and on track. Most students tend to get a 4-year degree prior to coming into the College of Pharmacy. And the University of Arizona actually offers a bachelor's program in pharmaceutical sciences that lays an excellent foundation for students who are interested in pursuing a degree in pharmacy. In addition, the BSPS students are prepared for careers in any health science, right? They could potentially go to medical school, they could become nurses, they could go into drug discovery, lots of interesting things. But for the students who choose to come to pharmacy school after completing that program or through a different path, at that point they begin their journey to becoming a pharmacist. So pharmacy school consists of typically 3 years of didactic in-the-class education where they are learning disease states, guidelines, medicinal chemistry, biochemistry, all the things that are necessary to become a pharmacist. And then their 4th year is typically spent doing clinical rotations where they work under the guidance of a practicing pharmacist, also known as a preceptor, who then helps them get real-world experience in taking care of patients. After those 4 years, they get a degree that says Doctor of Pharmacy on it. They get this cool hood that is conferred to doctoral candidates, and then they face a crossroads. For any 4th-year pharmacy students currently here or first-year residents who are eagerly anticipating match results tomorrow, you know how much of a crisis point this can be, trying to figure out what that next step looks like. So with a PharmD degree, recent graduates are ready to enter the workforce. They are eligible to take their licensure exams and begin working. But a lot of students choose to do a residency training program, a postgraduate training program, that's focused on building their skills as a pharmacist. For pharmacists, residency training is optional and typically consists of a 1-year sort of general experience. It's typically focused on either acute care or ambulatory care. After that 1 year, if they find something that they're really excited about or something that they want to specialize in, they can choose to do a 2nd-year specialty residency. So for me, I did a 1st-year residency general practice at a hospital, and then I did a 2nd-year specialty residency training program at the same hospital to learn how to be a really good emergency medicine pharmacist. There are other post-grad training programs available as well, including things like fellowships. Typically, these are sponsored by industry and teach recent graduates how to become outstanding researchers and how to work in that world. And there are other degree programs as well, such as dual degrees where you can become a pharmacist and nurse practitioner, pharmacist and physician assistant, pharmacist and an MBA, pharmacist and a Juris Doctorate, and many, many, many others. So lots of paths available to newly minted PharmD, and everybody's journey is a little bit different. So this is just the tip of the iceberg. We only had 20 minutes to cover an entire field of study, but there are a lot of different career opportunities out there for pharmacists, and there are a lot of ways that pharmacists are currently innovating in lots of different spaces right now. Unfortunately, we didn't have enough time to touch on many of these topics, but hopefully you found some of this information useful.
Come to a future PharmTalk.
Yes, come to a future PharmTalk. We'll be addressing some of these other things. Our ask of you, though, since you guys are engaged members of the public and you hopefully like what pharmacists are doing, is when you hear legislative issues come up that pertain to pharmacy practice, our ask is for you to be supportive of pharmacists practicing in Arizona. A lot of the legislation that dictates how pharmacy gets practiced happens at the state level, and your state legislators really do drive a lot of this, and they really care what constituents think. So our ask is if you hear things like expanded scope of services for pharmacists, if you hear things like provider status, you hear things like funding for improving the longevity of our patients and aging gracefully, these are all things that we really care about and we would encourage you to care about as well. So with that, we're we'll take any questions that you have. Okay, I saw that hand go up first.
I was quite stunned by your quotes that the patient was on 52 medications.
Yeah.
I was working in pharmaceutical industry. We had a guideline that patients shouldn't be on more than 8 medications at the same time, with some exceptions for rare genetic diseases. Did that FDA guideline go out the window, or what happened?
Yeah, no, patients need to be on as much medications as they need. This specific patient actually went above and beyond and started getting a bunch of supplements as well that they thought would help aid in their disease states. Those were kind of the quick wins to look at. Some of them just happen with maybe a mail order pharmacy where they get their medications mailed to them and then the prescriber prescribes another med and then those continue to come to them, and then they keep getting medications, more and more medications. I know I've heard stories in the VA of patients coming in with just trash bags full of medications, and those ones, which is probably a good thing, aren't taking them. They're coming to see what they should be taking, type of thing.
Yeah, I've seen it with my father-in-law who had like 5 different ACE inhibitors.
Yeah.
Wow.
Yeah, exactly. Don't need the duplicate therapy.
Taking them interchangeably, and I was like, no.
It's amazing on what some patients choose the bottle of the day and will take it. And so it's really working with them to coordinate and ensure that they're taking their medications the way it's supposed to be taken so they'll get the best benefit. Yeah.
That's great. So another question up front.
How do you determine if people get in the hospital because of insurance? Use a generic or regular medication?
Yeah, that's a great question. So in the hospital, so generic medications have to be equivalent to the brand medication, right? And so when a generic is available, as long as it's considered to be the same, we will use them interchangeably in the hospital. Typically, generics tend to be cheaper, and so those are typically the formulary agents that we'll have on the shelf in the hospital setting. And so, it's one of those things where if everything else is equal, then cost becomes the main driver. And since generics tend to be quite a bit cheaper, and we know for a fact that they're exactly the same, those will be the ones that we'll go for. Good question. Yes?
So you mentioned advocating for legislation.
Yeah.
In the past 4 years, do any bills come to mind, or is anything coming up in 2023?
That is a great question. So there was a piece of legislation that was drafted and being considered for this legislative session that would essentially change the way that the state Medicaid program access treats pharmacists and would essentially change the wording in that to allow them to be considered as providers, which would be a big win for people who are doing things like Dr. Cornelison, where you're seeing patients in the outpatient setting. You can then bill at the provider level. Now there's some ability to bill, but I think you get like $20 or something. It's a very small amount. Whereas if the patient sees a physician or a nurse practitioner or a physician's assistant, they can get compensated for their time. That piece of legislation got got tabled because there was concern that with the current composition that it probably wouldn't get through. And rather than having it just get beat up, the thought process was to sort of wait a little while until we have a more favorable composition in the state. I think it was the state house that they thought it wouldn't fly through. But that was really the big one that comes to mind. But again, if you hear those kind of terms come up, those sort of things will really help us to advance pharmacy practice and practice at the top of the license and use the knowledge and skills that we have to really take great care of patients. Really good question.
And if I can just add
Please.
to that, so say you have a friend that has an uncontrolled chronic condition and you think a pharmacist may help them out with it. Maybe they're not taking their meds right, or they are like, I hate this medication, I'm never going to take it. Can a pharmacist recommend a different one? I know that if you were to look us up in the Banner directory, you'd be able to find us as a pharmacist that could help. So maybe referring somebody to a pharmacist. I think the more people that know about what we do, the better, and that doesn't hurt. So then when things do come up, people can speak to it and feel comfortable doing that.
All right. Well, we don't want to take up any more time from our next speakers, so thank you all so much. Oh, Sure.
So you can take your medication by speaking to a pharmacist, or do you have to go to the doctor?
Typically, that's got to be done by a prescriber. Yeah. So the question was, can a pharmacist change your medications? In the outpatient setting, it's tricky. Typically, it does require a new prescription, and that can be written by your provider. Good question.
I can write a prescription. So sorry, just to make sure. So if you have a doctor that works with a pharmacist, then that doctor would refer you to the pharmacist, and then that pharmacist can prescribe that medication for you. Yeah. If you go to Walgreens and ask them for that, they'll be like, "What?" Yeah. But if you get that pharmacist that's embedded in the clinic. Mm-hmm.
Nice.
They'll call a doctor for you at a Walgreens. There's our Walgreens manager. They'll work with you. So yeah, we're all there to really make sure the patient gets the best care. So yep. Yeah. Right. So the patient population I work with is mainly Medicaid patients, and then those that are self-pay. And so the underserved population, I have a lot of patients that are Latino or even refugees. And so we bill Medicaid, and Medicaid may or may not pay, but the patient doesn't ever have to pay out of their pocket. When you get into more of the private insurances, they may cost, but right now, again, the visit's like maybe $20 for the hour.
All right. Thank you guys for all of your engagement. Thank you.
Thank you very much. Our second topic is meeting a critical challenge, aging and age-related neurodegenerative diseases and disorders. Average life expectancy has doubled since the early 1900s. It is anticipated that more than 90 million Americans will be over 65 years of age in 2050. It's scary. This is an extraordinary achievement toward greater longevity and has been accompanied by dramatic increases in age-related neurological disorders such as Alzheimer's, dementia, Parkinson's, and ALS. So the Coit Center for Longevity and Neurotherapeutics co-directors, Bernardo Lemos and Hangning Zhu, will now share their research on promoting longevity and improving quality of life as we age. Please.
Can you hear me now? Yeah. All right. Well, I'll start by saying a huge thank you. Thank you for all to come here today. It's our hope that this is the beginning of many of these events. It's an event for the public, for you all. It's a conversation. I also take a pass and say that you can write emails to all of us, and that's okay. Maybe also to Dean Schnellman. We won't be too mad. Stay in touch. That's the message. So this is the beginning of many. It's for you all, and the hope is that we stay connected here. Dean Schnellman already mentioned the Coit Center for Longevity and Neurotherapeutics with a mission to foster new discoveries towards healthy aging and new therapeutics for age-related diseases. That's sort of the broad-based mission of the center. There's a link there. I encourage you all to go and take a look. And the question here is, why are we so worried about aging? It is terrifying. And the reason is because it affects us all, but it's also the single most important risk factor for disease. If there is anything you'd like to know about someone, if you ask the question, what's the risk of that person for a certain disease, and you know nothing about that person, you'd like to know the answer, how old that person is, above and beyond everything else. And if you were to put in a graph the other risk factors, they're much, much smaller. Even if you're a smoker for lung cancer, that risk is much smaller than the risk of aging itself as time passes. So that's really, really important. It is going to affect us all. So keep that in mind. The other aspect of aging that at least fascinates me is that aging is universal. We age, but also rats age, mice age, our dogs and cats, the vipers around in Arizona, they age just the same, hummingbirds, even the fruit flies are on the banana age. Single-celled organisms, the ones that we use for making bread and beer, fungi, single-celled, they age as well. So it's something like there is something very fundamental about the biology of aging, and that really, really, really impact the risk of diseases. And the last thing about aging that I don't think we all realize, even in the scientific community, it took a long time, is that aging is a modifiable risk factor. Okay, we can act on it, and it may be through therapeutics, through lifestyle changes. It's something we can move the needle a little bit. Of course, we all continuously aging over time, but you can switch that. And what we'd like to do is to decouple in ourselves, decouple chronological and biological age. So what we have here is a person on the top, let's say Susan, and I have the person on the bottom, let's say Mary. They both have, that's the dotted line there, the same chronological age. But the person on top, her clock is moving really, really fast, so faster than the one from the person below. So even though she's 45 chronologically, she has an accelerated clock, and will therefore present with a greater number of age-related diseases and earlier in her life. The person on the bottom, on the other hand, has a slow moving clock and will present with age-related diseases later in life. And for that reason, the person on the bottom has what we call a greater health span. Okay? Even though in this case, we're showing here in this picture both of them to have the same lifespan. And so the question is, can we measure that decoupling to begin with? And the other question that we have in the center and in the college is, can we think about interventions that will increase that health span? And the answer is yes, we can. We can measure at a very fundamental level the biological age of cells and humans and organisms. And the way we do that is that we look at, and I'm really here talking to the public at large. I don't want to embarrass me in front of my students, but we're talking about some very, very, the basic biology of the cell, mechanisms of gene regulation and packaging of the genome. So you think about the DNA you get from your mother, the DNA you get from your father, they all come together, they stay inside the cell nucleus. So we'll think about the cell as a balloon. Inside the balloon there's another smaller balloon. That smaller balloon is the cell nucleus, and that cell nucleus has to package a whole lot of DNA. And the packaging of DNA, that DNA involves what we call epigenetic marks, chemistry around the DNA that sort of allows the packaging and allows the organization of the genome, the functioning of the cell, really. And that these chemical marks are labile. They change by the drugs we take, by the things we do in our lives, by the diets. And by measuring those, we can then, we went on to develop this technology, and I mean the field as a whole, we have some flavor of that technology, which is a technology to measure biological age of cells and individuals. And what you see there in this graph, and I was really trying to stay away from graphs, but this one I had to show you. What we have there on your left is a correlation between chronological age, so the age that we get from birth and we measure every day as time passes, and then biological age on the y-axis. And these are data from humans, and you see this very nice correlation. But this is a small sample. If you should sample a much larger number, what you're going to find is that there are people with a greater and people with lower biological age for his or her own chronological age, and that matters, we came to learn. So what you see there on the left side is data from mice. And that comes to the point I made at the beginning, that biological age is something that we can intervene on. And one way to intervene in aging is through an intervention called calorie restriction. That is the single most sort of successful intervention thus far. So the less we eat, the longer we live. That has been shown to be true in mice, in rats, in fruit flies, in worms, across the board, even the single cell yeast, and sometimes 30% longer. And what you have there are mice, in black control mice, if you will. These are mice grown in cages. They eat as much as they want. And you have their estimate of biological age. You see the very nice correlation between chronological age and biological age. You see there is greater dispersion as they become older. So these mice, somehow they're young in a similar way, but as they age a little bit differently. But what you have there in blue are mice that ate less. They were they were forced calorie-restricted diets. The intake was not that much smaller. So I mean, again, we have to, caveat here is there was nothing about malnutrition or not eating at all. These mice are eating a little bit less than the other ones, and by that I mean 15%. And you can see that their biological age decreases. And we also came to learn, and not just us, but through many studies, that these mice tend to have much greater longevity than the ones that didn't go through that treatment. All right, so the answer is yes, we can intervene on aging. We can through, and there are now pharmaceuticals being developed, and some of them already FDA approved and being tested for whether or not they can increase lifespan. But eventually, as we increase lifespan, the outcome is that we are going to live longer as well. So as we increase lifespan will increase. So eventually, those arrows there will hit us, and they will hit us with diseases of old age, no matter what we do. And that those diseases will be cancer, will be cardiovascular disease. We can prevent them, but eventually they will hit us. And the ones that we are focusing here in the center is neurodegenerative diseases. And I'll pass the baton here to Dr. Zhu. Thank you.
Well, great, thank you. Dr. Lemos told you generally about aging, and I'm going to tell you a little bit more about a group of diseases called neurodegenerative diseases. Typically, this is a group referring to Alzheimer's disease and the related dementia that most people are familiar with, and then Parkinson's disease and ALS, or amyotrophic lateral sclerosis. And the numbers are staggering. About 5-6 years ago, this group of neurodegenerative diseases together are estimated to impact about 5 to 6 million Americans in the United States alone. And the worldwide number is even much larger. And they account for about 3 million disability adjusted every year. Okay, so that's and it's growing as well. And it's part of this is age related. And it's take an example as Alzheimer's disease. When people reach the age of 80 years old, and the risk is considered about 1 out of 3 people will get Alzheimer's disease. And now, since we're in Arizona, let's take Arizona's number. And about 2 years ago, 2020, it's estimated approximately 150, just Alzheimer's disease alone, 150,000 patients. In about 5 years from 2020, by the year 2025, the number is estimated to grow to 200,000 Alzheimer's disease patients. That's tremendous increase of this. So what we can do? Can we study this disease and try to figure out some better therapeutics? And our pharmacists will be happy to distribute to you all. Right? So I'm going to, we have some labs study Alzheimer's disease in our center and in our college, but my own lab studies this disease, amyotrophic lateral sclerosis. How many of you remember Ice Bucket Challenge a few years ago? Many of you. How many of you did it? Oh, a few. Oh, that's great. I think it's appropriate in summer in Arizona to get that cool. So this is, I think I found it in the website. Our pharmacy did it. That's great. And here's a little bit number that globally, this is a relatively much smaller number. And in the United States alone, it's about 20 to 30,000 patients each year. Okay, there's a reason for this. There's many reasons for this. So fortunately, this is still relatively rare disease, but it is a very horrible disease. The disease. So the median onset is approximately 55 years old. I'm not a neurologist, but I have a great collaborator, so I can generally describe to you what these patients looks like, what is they're enduring. So typically the patient will start with muscle weakness. And that many different reasons can cause muscle weakness. So you go to see your family doctor, eventually it takes about several months to a year. Typically the patient will get referred to a neurologist. They rule out this, they rule out that, couldn't figure it out, they will get to see a neurologist. And then over that 6 year time, typically you will start from one side of the arm or leg. Some patients start with arms, some start with leg, and then just progressing pretty quickly, and then migrate to the other side by the time you see neurologist, and then they do a bunch of tests. There's no specific diagnostic test. They have to do a battery of different tests and then rule out other possibilities, and then this patient get diagnosed with ALS. Basically, is a death sentence. There are a few, now about 3. There's one Redzol has been several years, and in the last 2 years, patient group advocates some two treatments that are very marginal in the clinical trial, but these patients are willing to take anything. Okay, so now there are 3 FDA-approved medications. And many of these patients typically would only survive about 3 years from the diagnosis. That's one of the reasons that there's not a huge living patient population. When I give talks, people will tell me, oh, I know so-and-so, but he or she passed away quickly. That's very typical, unfortunately, for this patient. Now, and in the United States, the disease is known as Lou Gehrig's disease for this Yankees baseball player. And to make it a little, to make this unfortunate and sad facts a little bit more interesting, I put a little data here. This is actually Lou Gehrig's batting average. The top 2 lines, his batting average in the season of 2036 and 37. Everybody knows that he was a great baseball player. But during the season of 1938, his batting averages declined week by week. And by the end of the season, he couldn't hit the ball at all. It's just how rapid this disease progresses and consumed this Iron Man great baseball player. And he was diagnosed and he passed away a year later. So this is that. Now, so we really in the lab, we try to understand what caused the disease. So in order to develop therapeutics, we need to understand what the problem is, how this damage occurs in these neurons or in the central nervous system. And so we study a lot of this. What's shown here is a motor neuron. So that's a very subset of neurons that control our voluntary muscle movement. For example, I'm standing here, I'm speaking, I'm breathing, I'm waving my hands, etc. Every command comes from my brain, travels through the motor neuron, tell my finger to do this, right? So everybody can do that. But unfortunately, I had some videos as an ALS patient. We had some video that the doctor tells them to hold the hand. They couldn't because they are so weak, their hand would drop like that. So this is the neurons that are having the trouble. You can see that the neurons dying back, and some of the proteins are the working machineries in the cell in our human body, can travel in different places of neurons, and obviously from a healthy one on the left and the unhealthy disease one on the right, you see some differences. So we try to understand what the difference is and what caused the differences, and can we reverse the damaging process. So, and I'm trying to brag a little bit about what we show in the laboratory. We try to recapitulate these differences. For example, the one on the top, the very top ones, the healthy ones, and the bottom ones, the disease ones, there's the protein's distribution changes. And they form those large things, bright up in the microscope images. So we can recapitulate that in the lab, and we try to make this as a measurement to see whether we can put some intervention to either stop the process, disease process, or even better, to reverse the disease process. So this is a Science magazine about 2 years ago. This is showing to highlight the neurodegenerative diseases and showing that people's minds are blown away. That's a pretty good artistic illustration of how damaging these diseases are. And so here's a technical jargon called aggregation. So how many of you heard about A beta plaque in Alzheimer's disease? So those are a type of aggregation. So it appears this aggregation of different proteins in the nerve system appear to be a hallmark of multiple neurodegenerative diseases. And we study specifically a process called the stress granules that leads to protein aggregation. So that is a process. You got a lot of those. Each dot is a protein. They start putting together, assembling together. And if this getting chronicle and then become irreversible, they become a plaque per se. Okay. And so we studied that process, and we really recently, last year, we published a paper, get to the core of this process called stress granules. And I'm showing you this structure that, because we think if you can you see that in that bee, that gray saying, looks like it has a little cave, little pocket? Can you see that? I don't know whether this has a laser pointer. But on the right, in the middle, right there, there's a little pocket. So for biochemistry or medicinal chemistry, those pockets in these proteins usually indicates there's somewhere you can put a drug there. There's somewhere you can put a small molecule therapeutic agent, put it there, and change the protein function. That's exactly what we're trying to do. So these are the name of those proteins, and the three of them interact together, and that's a real at the atomic level how they interact, and we see a pocket, and then we're trying to screen a small molecule drug that can sit in that pocket and then disperse these three partners away, and to see to modulate this stress granule process to see, and we want to test whether that can modulate the protein aggregation process. So that's one of the projects we're working on, and we already got some hits, and we're really excited to see whether we can move this from the pure laboratory research to move into the animal testing, and eventually whether that can translate into clinical trials. And if that's successful, I know the chance is small, but we got to try it, right? So, and if that clinical trial is successful, this may one day. I heard usually it's between 10 to 15 years. Hopefully, we may make a little bit shorter, and so we can bring this to the clinical application to help these patients. All right. So research takes long. So this research actually takes even longer. So this is a pedigree of familial, meaning there's a family history of this patient, okay, of this ALS patient. This diagram take our clinical collaborator and his research nurse about 30 years to assemble them together, because across 3 different generations, it's taken them 30 years to see these patients across 3 different generations, then realize they have family history. And then take his research nurse 10 years to go through handwritten census card 100 years ago, or type into ancestor.com to figure out the relationship between these people, and we put them together. And one particular reason, and I'm putting this, not because we spend a lot of time, but it leads to the next slide. So here, we're building 5 minutes. Okay, yeah, this is the last slide. Great. So we're building a new platform to address this, neurological disorders. So when someone has cancer, a lot of times you heard about the word biopsy, right? So this patient will go to doctor, get a biopsy even for diagnosis, or during the surgical procedure, you get a piece of tumor that you can take back to the lab and to study. That's real patient material to study the disease, what's going on in the human. And we in the laboratory, we use model systems. We don't for neurological disorders, it's very difficult. You cannot take Alzheimer's patient, do a biopsy in his brain or her brain, right? You never heard of, you can. It's astronomical to biopsy someone's brain. So we are very limited by but in the research, the most thing we get is postmortem tissues. Usually get a snapshot of the very end stage. We did not know what happened years ago. So now, knowing all the pedigrees, and then we can take these patients and their family members, and sometimes you get very interesting findings. They're related. So what we can do is we can take a skin. So many of our patients is willing to donate a skin biopsy, 3 millimeter round punch. It's a little painful. I actually donated myself too. 3 millimeter, that's okay, right? We can take those skin cells and we can transform into skin, into adult stem cells. And from the stem cells, as you know, that this is not embryonic, so nothing involved in that. This comes from an adult patient skin, and we can derive into many different types. We can even grow an artificial brain, like what we call the organoid, on the dish in the laboratory. So now we can recapitulate a neurological system. It's not perfect, but they come from this patient. We can take this system, we can study the disease mechanism, like what I described earlier. We can do biomarker, like I told you, ALS, there's no diagnostic test. And also, we can do this drug screening, and we can use this better system instead of some other less reliable system. So this is where we are, and our center together, we want to use this platform and to accelerate our discovery, to find some better, more effective drugs, and bring it sooner to the clinic application so we can have, to achieve our goal to make people live longer and healthier. So I think I'm turning back to Dr. Lemos.
I think this is. I think maybe we can have questions.
Okay. All right.
Yeah.
Any questions?
Thank you. So, in your graphs, you showed that caloric decreases can decrease biologic aging, but is there factors that affect or increase biological aging? So you see something a little more like that bottom person where you see their health spans a little bit farther along, and to what extent would that affect the prevalence of neurodegenerative diseases in younger populations?
Thanks for the question. That's great. The answer is yes. So there's plenty you can do that will accelerate your clock. And things like smoke, things like a lack of exercise has been shown to increase aging. There is a big gap there in understanding environmental influences, things like toxicants. There are here in Arizona, we have exposure to arsenic. That in some populations, it's substantially high. There are gaps there in understanding that particular case where that increased. But the answer is yeah. So there are plenty of things that have been shown to increase your biological age. And most of them are sort of lifestyle things. Also stressors in some cases, some populations have been shown. Cortisol.
Can you tell me about something that you've seen recently or that you've been reading about or working on that really excites you in your field, or something unexpected that surprised you?
You want to go for, every day. So that's the beauty of, so I will say this to everybody, the beauty of science and discovery. If you stop being surprised, you're not doing it right. So just, and you might be doing the discovery yourself, but oftentimes the discovery happens in the library. If you read something and say, is that right? And you get excited. So every day. About aging, we're reading and we find out the people's findings in neurodegeneration, I'm sure too. Just this morning we had a wonderful talk about Alzheimer's disease, and I learned some really exciting things at 11 a.m. on Tuesdays for those who are in the PharmTalk's department elsewhere want to participate.
I was wondering what process you're using to convert the skin cells into stem cells.
Yes, so there are several different protocols that can convert that, or what we call reprogramming that. So the one that's commonly used, that what we use here, is using some genetic factors to drive back skin cells to some initial cells in the early, mimic those cells in the early stage of development. That's why it's called adult stem cells. Yeah. If you're interested, I can tell you more later, but basically we're using genetic factors. Yeah.
My question is about biological age. Athletes, especially with hard contact sports, I mean, they're damaging their body. Has anybody done research on that? I mean, football, MMA, boxing.
Yeah, so right now we're engaged in research that has to do with exercise, and that one is what cardiovascular exercise, and the indication seems to be that it helps. But then there's also, in that particular trial, they're kids really, they're entering college, and they're subject to a very high caloric, they want to be football players. So they have a very high caloric diet, and they are going through everything you described in their practice of the sport. We don't know the data for the biological clock there yet. We do know the cardiovascular parameters go down really quickly, and I'm told by my cardiovascular friend, medical doctors, that these kids within 6 months they show cardiovascular sort of aging in a particular way that they measure.
Can I add a little bit on that?
Please.
So Dr. Lemos illustrated some beneficial, mostly people think beneficial from exercise. That's absolutely true. We should exercise. But if we think about some extreme athletes, they potentially could be damaging. There's a well-publicized study of NFL players. They suffer from concussions, say, for example, and decades later, they have higher chance of getting Alzheimer's disease. So that's well documented and well publicized. I see many people, you're nodding. And also in ALS field, there was epidemiology studies in Europe showing those elite Italian soccer players, they have higher chance of getting ALS. We did not know why, but probably some extreme sports may cause some unintended effects.
Yeah, and those effects in the brain often come, the jargon would be traumatic brain injury, hits to the head repeatedly, even if you're hitting a ball, not necessarily a good thing.
They probably headed too much.
Yeah. Yeah. I think also, to balance here the answer, without want to take too much time, we want to balance, the hits, but also the sport is a good thing overall. So there are ways to do it safely. I would not recommend anybody to stop, stop running. Yeah.
Okay. All right. Thank you.
So our final topic of the evening is cannabis in the community, a poison center's response. So marijuana was legalized a few years ago, and Steve Dudley, the director of the Arizona Poison and Drug Information Center, is here to discuss what has changed since legalization, what dangers may exist, and what you need to know about marijuana to keep you and your loved ones safe. So welcome, Dr. Dudley.
Since I'm presenting solo, I'm just going to stand here because the whole chair thing, I don't have someone else to off-balance that. So thanks. My name is Steve Doley, Director of the Arizona Poison and Drug Information Center. And again, we're going to talk about cannabis, what we've learned from our experiences, our perspective from the legalization of recreational or adult use cannabis. So a little bit of background. So there are 2 poison centers in Arizona. I'm director of the Arizona Poison and Drug Information Center. We're located here, just literally across the street in the College of Pharmacy, and we cover all of Arizona except for Maricopa County, which have their own poison center, which is located in Phoenix. And so poison centers do more than you think. I think people think of, oh, little Timmy got into the bleach under the cabinet. We got to call poison control, see what they're going to do about it. But really, we are a poison and drug information center. Pretty much anything you can think of, we've gotten calls on, especially here in Tucson. The saying in the poison control world is the dose makes the poison. And so if really you can overdose or have toxicity on anything, and if we're a poison center, we get called about anything. So I think some of our most exciting ones where we get calls about like tiger bites, which it's Tucson. We don't have tigers here naturally, but we'll get called about it, right? And so with cannabis specifically, we have been asked by the Arizona Department of Health Services to stand up a medical marijuana line when medical marijuana was passed back in 2011 for questions about what are the drug-drug interactions, what are the indications, safety profiles, things like that. And so when recreational was passed or adult use was passed, they asked of us the same thing. And that's what Prop 207 was. Prop 207 was the Smart and Safe Arizona Act, which legalized adult use cannabis. And we were the 13th state that passed that. And so in every other state, you had the same experiences, and you had poison controls in these other states having the same sort of response and the same sort of, again, experiences from what they learned. So this was nothing new for us. And so when we saw this was happening, we are neither pro nor anti-cannabis. If it's going to happen, it's going to happen, but we want to make sure that people are safe. And so because we saw this happen in 12 other states, we knew that there were going to be some common recurrences or some common themes. So we had our poison center predictions. And the prediction was we are for sure going to see adults try this because it's going to be incredibly popular. And we are for sure going to see little kids get into this and have some bad outcomes, toxicities, hospitalizations, et cetera, because that's what kids do. They get into things. And sure enough, we were right, unfortunately, right? And so if you look at this graph here, what you're seeing is over a 3-year trend of calls to our poison center related to exposures for cannabis. And so the red graph is for 2020, light blue is 2021, and dark blue is 2022. And so on the furthest to the left is our adults, 20 plus. Then you have kids 0 to 5, and then pediatrics 6 to 19, or kids 6 to 19. And I know 19 is kind of a weird cutoff for kids. It's just a poison center coding thing. But what you see here is you saw in 2021 when Prop 207 went into effect, you had a huge jump in the adult population. Not really surprised. Cannabis was incredibly popular. You had people trying it for the first time. And you also had medical and recreational sales happening. And so people who have been using it medicinally have been using it for about a decade or so, and they have tolerance. So they can take a 50, 75, 100, 500 milligram edible and be okay. That would knock pretty much anyone else on their butt. And so what we saw was exactly that. The other common occurrence is because this is new and edibles are so popular, you would see people say, oh, I'm going to try this edible, and 5 minutes later, nothing happened. So what do? That's weak. I got to take more. I have to take more. Not knowing that it takes about 25 to 30 minutes to feel those effects. And now half an hour later, they've taken 40 to 50 milligrams and they're on their butt. Again, the same thing we saw as well was package size and product size. And so if anyone's ever seen edibles, they have like the gummy bears or gummy worms. You have these products that are in these packaging, but you don't understand that the dosing size is, one piece or a part of one cookie. And I personally do not like gummy bears, and I've never only eaten one gummy bear, and I don't like them, right? So if you're someone who likes them, eating one gummy bear is not a serving size for us. But when we saw this, though, you had these increase in exposures in 2021, but with adults, people learned their lessons for the most part, fairly quickly, right? And so, based off our outreach and just, people kind of learning and adjusting to the new world, you saw a decrease in 2022 for exposures for adults. Unfortunately for children, that wasn't quite the case. So we did see the initial increase. Again, we knew this was coming, but the problem is for the 0 to 6-year-olds, these are exploratory ingestions, meaning that they are getting into something, it's unintentional, it looks enticing, they're curious, they pick it up, they eat it, and then they have a bad time. And so really, even though we knew this was happening, we tried to get ahead of this as much as we could, get messaging out there, do outreach. We still saw another slight increase in 2022. And that kind of goes to show you kind of how big of a problem this is. And so what you're looking at here, these are example of edibles, right? And so if you look really closely, you can see the names of them. So the top one that looks like Captain Crunch is actually called Crunchy Caps. Right, and then the bottom left that looks like Fruit Loops or Loopy Fruit, and then the bottom right that looks like Cinnamon Toast Crunch is Toasty Crunch, right? And so if you don't know any better, like as an adult, I would eat any one of those bowls without second guessing myself, right? But when you don't, we have something like this that looks really appetizing combined with a very curious age group, you're not going to have a good time, and that's exactly what we saw. And so really we have to go through with the patient education of saying, hey, if you have young children in the household, you got to make sure you store this stuff safely, because this is confusing for adults. Little children don't have a chance. And then on top of that, we talk about patient education. It also comes down to adults who are intentionally using these medications or using these products for any sort of reason to make sure they understand what they know. And so part of this is what's the difference between THC and CBD. I think I was actually talking to somebody earlier today about, someone who's using these products for sleep. Well, is THC really where you want to go, or are you looking more so for CBD? We see medicinal uses for both THC and CBD for things like seizures and whatnot, or appetite stimulation. But again, that's not all the same. Even though we all clump together as marijuana or cannabis, it's not quite the same thing when you start to break it apart. And the problem was, we surveyed pharmacists across Tucson, and about 60% said they were not comfortable counseling about cannabis because we don't learn this in school. When I was in school, this was still federally illegal. We don't really talk about that. And so now that you have this product out in the streets, who's going to answer those calls? Who's going to be able to provide those recommendations? And that's something that us at the Poison Center really try to step up and answer that need for, because again, we knew this was going to happen. And what this excerpt is a news release we put out that says, when it comes to drug testing, CBD may not be A-OK. And what happened was we had a physician in Arizona who was taking CBD edibles for chronic pain. It's for inflammation, essentially, so swelling in the joints. And this physician thought they were doing the right thing. The CBD was working well for them, and they worked for a hospital where they drug test. And so to this physician's mind, well, they're not using THC. It's part of their zero tolerance policy, but they're using CBD. That's different. That's okay. Well, then come to find out, they had a drug test, and they tested positive for THC, and they lost their job. Now, unbeknownst to this physician, what happened was you have these products that, even because there's no real regulation or strict enforceable regulation, you see that these CBD products, they say, all CBD, no THC, actually have THC in there, and that's a problem, right? And so if this can happen to a physician, someone who's trained to know better, it can happen to anybody, right? Anybody in the general public. And so again, the education that goes out there to understand that maybe what's on the label isn't necessarily what's in the product itself, but also understanding what kind of risk comes with this, things you may think about and things you may not. And so in this example, one of the things the Poison Center did was really go out, call some of the labs around town, and promote the fact that there are testings for CBD to THC ratios. And so normally what this means is if you take a drug screen, it's going to tell you, are you positive for THC? Are you positive for CBD? Yes, no. And typically speaking, if someone does consume cannabis or marijuana, you're going to see about a split of each. A little bit of THC, a little bit of CBD, ratio maybe 1-to-1, or a little bit higher, a little bit lower, but you're going to have both in pretty near levels to each other for the most part. Well, if you took CBD product and then it was contaminated with a little bit of THC, well, you should have a ton of CBD in your system and very little THC, right? Because it's not supposed to be there. There's small levels, and that sort of confirms your story that you weren't actually using cannabis, you were using a tainted CBD product. And so that's what we went out with. We actually worked with the physician and worked with some other providers in Arizona to get this message out there so people aren't unnecessarily losing their jobs. And these These people are innocent sort of victims in the game of a lack of regulation. And so you have that, and then you have like full-blown product fraud. Full-blown, hey, this is one thing over here, but it has the completely other thing inside of that. And again, this because there is no regulation. What we see is that consumers are the ones who suffer from this. So what do we do about it? What was our response, right? So we talked a little bit about what we did in that scenario with the CBD products, but really we're trying to get ahead of what we're seeing nationwide. And the beauty of the poison centers are that all 55 of us are connected together, so we do have a similar or the same reporting system. And so someone's always looking at all the poison center cases nationwide every 8 minutes as it enters to the poison center records. And so one of the things that we saw was this product called Delta 8 THC. And so when we think about cannabis, we think about THC, right? THC is a psychoactive thing. THC gets you high. Well, when we say THC, we really mean Delta 9 THC, exactly. And what happens is when you look at the Farm Bill, I'm not sure if anyone's ever heard of the Farm Bill, show of hands. Anyone's ever heard of hemp, show of hands? Right, okay. So the reason hemp is legal is because of the 2018 Farm Bill. So very, very simply put, what happened was the Fed said, okay, we have a bunch of these other byproducts from cannabis plants that's not gonna get people high, but it's really good for things like, paper milling or rope and things like that. We should be able to use these products for just consumption, and not for human consumption, but just for use, right? And so they said, okay, any plant or any product that contains less than 0.3% Delta 9 THC is not really cannabis. That's not really marijuana. That doesn't count. You can use that for all these other productions and be legally okay. We're going to call that hemp. And so what happens is if you look in a cannabis plant, there's going to be some bit of Delta 9 THC, but it's going to be a very, very, very small percentage of Delta 8 THC. Delta 8 THC will get you high just like Delta 9 will. It's just in very small concentrations. No one ever thought about Delta 8 when they were making the law. And so what happens is that of this hemp product that's not supposed to have any psychoactive effects, you have a bunch of CBD as well in there too. CBD has no psychoactive effects. It's not going to get you high. But you can convert CBD to Delta 8, which will get you high. And Delta 8 is technically not illegal. So if you put 2 and 2 together, I can get a product that can get me high. It's not illegal. There's no regulation. And I can make money on that. You kind of see where this is going, right? And that's exactly what happened. And so because we don't have regulation on these products, we saw a wave of Delta 8 products come through, first in states where adult use or recreational cannabis was still illegal, because again, it's a legal high. And then you saw it in states where you had medicinal and recreational cannabis legal because it was a way to skirt the dispensaries. You can literally get this in smoke shops, like vape shops where you get your tobacco and nicotine. You can get it from grocery stores. So your access is pretty much unlimited. And so that's something that we really have to work with to get the word out, to do better surveillance of, and inform people, not just for the toxicity effects, but training providers, doctors, pharmacists, et cetera, that, hey, you can see these products. Don't lump this in with a regular marijuana or the regular weed or cannabis or whatever you want to call it. These are a different breed. And then working with patients, specifically parents, to say, hey, listen, these are products that are really easily accessible to your children. And then also working with youth who think that, hey, this product is like ibuprofen or Tylenol. I can go get it over the counter. It must be safe. Yeah, that's not true, right? And so to do that, we had some partnerships that we had to really come together with. And the big one was the Arizona Dispensary Association. And so when adult use cannabis first was legalized, we want to get the word out saying, hey, listen, if you're going to use, that's fine by us, but make sure you're safe. One of the things that we have to talk about was, we mentioned earlier with polypharmacy. Well, if you look at the medical marijuana numbers, 1/3 of all medical marijuana cardholders in Arizona are over 50. Right? And as we age, we take more medications. But because we don't study cannabis, because it's federally illegal, no one really talks about drug-drug interactions. it's a thing. We know it's a thing because we've seen it in other countries. And so it's one thing to say, oh, well, this is cannabis, it's natural, it can't be, it can't hurt me. To say, no. Well, this actually, while we don't have a ton of information, we do know it does interact with your blood thinner. That's probably a drug you don't want to mess with, right? And so, partnering with folks who can help amplify our messaging was instrumental for us. And so the Dispensary Association came through and said, hey, we understand your messaging. We understand that you're not trying to ruin our business. You just want people to be safe. Because no one wants kids to get poisoned. That'd be a terrible business model, right? And so it was really helpful because when we went to dispensaries without them, no one wants their product associated with poison. So the moment we say, hey, I'm Steve from Poison Control, they're going to say, get out. Get out, you're scaring the customers, right? But when you rebrand that and repackage that message and saying, hey, listen, we just want you to have your customers and your patients to have a safe time. We don't want toxicities. I think everyone can get on board with that, understand whether it's monetarily focused or just out of the goodness of your heart, we all have the same common goal. And so working with the Dispensary Association to kind of promote this messaging, put our phone number in there, be able to have healthcare professionals answer questions that folks in the dispensary can't because they don't have medical training, has been a huge win for us. And then finally, the messaging. Again, it goes back down to, listen, we're not pro nor anti-cannabis. We just want everyone to be safe. And so when you kind of take that sort of spin to it, it really did open up the ears and the arms, so to speak, for us to go in and do our part. So with that being said, our response so far, we're still pretty early into it. Again, I think we were the 13th state to legalize adult use cannabis. We're still learning a lot of these things, but above all else, the Poison Center is here to help you, help with any sort of questions that most people either may not want to or don't know how to address. And no matter what, we'll always be here for the public. So that is my time. I understand I am the last speaker and I don't want to keep anyone late here. So with that, I would turn it over for questions.
Is there anything that, a lot of people commonly say about cannabis or marijuana that is factually untrue, but they're proliferating a certain idea about cannabis that you would like to dispel at this time?
Yeah, that's a great question. So it goes both ways. I think this is clearly a very political battle, right? And so you have folks on one side who say this is the devil's lettuce. It should never be legalized. It's going to, be the end of times. And then you have people on the other side who say that this is completely safe. No harm can come from it. Consume to your heart's content. And they're both wrong, right? The truth lies somewhere in the middle where we do know that there are toxicities from there. Yes, this is not like fentanyl, right? We're not having people just drop dead in masses from cannabis exposure, but there are known toxicities to cannabis, especially in certain vulnerable populations, i.e. children, right? We know there are drug-drug interactions, so the elderly as well would be someone we'd be very concerned about. And like we said earlier, the dose makes the poison. And so when you look at marijuana from the 70s, right? That, this is not your grandparents or your parents or your marijuana from the past, right? As we know, the concentrations of THC have steadily risen year over year over year. And without getting too into the weeds here, when you talk about cannabis, it's what we call a partial agonist, meaning that it acts at a receptor, it acts somewhere on the body, and it gives you a partial response. It gives you a little love tap, a little push, right? But what we're seeing now is with these high potency items, whether it's from medicinal dispensaries or things like Spice we saw a couple years ago, which is synthetic cannabis, or with the Delta 8 products, these are full agonists. These are high potency things, and what you're doing is you're blowing past this sort of therapeutic range and you're getting into toxicities, mostly like psychosis and things like that. We do know there are effects on the cardiovascular system that we see more with synthetics than we do with traditional products. And so I think that's probably the biggest one that we see is that what's the harm profile? It's either completely harmful and deadly, or it does no harm whatsoever. And again, the truth lies in the middle. I will say the biggest thing, though, just as a pharmacist, is that it's still federally illegal. We call that Schedule 1, which means that there's no legitimate medical purpose. Yet we have dronabinol and nabilone, which are synthetic Delta-9 THC that are FDA-approved drugs. So a little bit of a hypocrisy, but we'll get there.
Hi, Steve.
Hey, Kim.
How big is your database for recreational drugs with FDA-approved drugs? Because sometimes I have patients, I can't answer questions,
Oh, yeah.
stuff like that. So I would have to do extensive research. So next time I could call you if I knew how big your database was.
Yeah, so when we look up medications or we look up drug information, we're using pretty much the same resources most pharmacists do, whether it's micromedics or in our case, Poisondex, which is a branch of micromedics, Lexicon. But the big thing we do is because we are the drug information center, we may not have the answer for you right away, but we do have time to, for the most part, do those primary literature searches, right? And that's what we've done for cannabis, is that you're not gonna find information in micromedics to the level that you need. But there's a ton of literature from Canada, from Amsterdam, from across the world that do highlight really well the effects, toxicities, and therapeutic uses of things like cannabis. And so we use that together, create our own internal resource to educate providers and the public. So yeah, give us a call. We're here 24/7.
Can you speak a little bit if the poison control is concerned about reproductive toxicity? And if so, do you think people should know about it?
Yeah, and so right now we also have in our poison center, we have an organization called Mother to Baby who specialize in this very thing. So we talk about reproductive risk, breastfeeding, fetal health, mother health, etc. And the reality is, to the level that we're comfortable saying, that we don't know because there's not enough evidence in the U.S. for this. And that's a perfect question we will coordinate with the Mother to Baby colleagues who specialize in the gray area. And I'll give you a quick example. We don't use it anymore, but pharmacists used to have like this pregnancy category ranking for drugs, right? And so A was it's really safe, X was never ever give this, are you crazy? And then C is we don't know. And as you can probably imagine, most people who are pregnant or having babies or breastfeeding are not going to subject their young ones to experimental drug testing for the sake of science. So a lot of the stuff lived in that category of we don't know. Well, that's where they specialize at. And so really what it becomes is a case-by-case analysis, if you will, versus a blanket statement. And I think as time goes on, if we have looser restrictions on just cannabis testing, researching in the U.S., that would open up a lot of doors to be able to answer these questions more definitively. So not to give you a cop-out answer, but we're relying on case reports, one-offs, things like that.
Hi, I just had a question real quick.
Yeah.
In your experience so far, since weed has been legalized for recreational use, has the majority of people that have gone to see or got help from the CDs or poison control, have they been from other synthetic like Delta 8 type THC or drugs, or are they from people who have gone or who are taking in high concentrations that they just can't handle?
Yeah, that's a fantastic question. I think it's one we're trying to understand a little bit better, because the problem is for the poison control, how we get involved is either the patients call us or the hospital calls us. And so once the hospital calls us, we are consulting with them, but we're getting our information from them. And so if you go to the hospital and the nurse or the doc says, oh yeah, this person just took a bunch of weed and that's what it was and they're sick, well then we have no other choice but to code that as that's marijuana, Delta 9 THC, when in reality it could have been a Delta 8, it could have been any of these products, we just don't know. So we're doing a better job at really kind of driving that point home to see what exact product was this? Was it from a dispensary? Was it from online? Was it from the streets? Whatever it may be. To your point, what we are seeing, especially in young children or even teens, definitely the synthetics are more likely to land someone in the hospital. However, even the quote unquote regular good old weed or cannabis is still with teens with chronic use. It's still exacerbating acute psychosis when it's a high potency item. So you have something that's really strong, a really, really strong product, and teens use that for a long period of time, pretty consistently, weekly, daily, whatever. We are seeing over time that they do have higher incidences of psychotic episodes or a GI issue called cyclical vomiting syndrome. And so you can see that with your natural products. But if you're talking about an acute problem, like, hey, this is my first time using it, I'm having an issue, it's more likely to be the synthetics than what we see in the dispensary, but the ones we in the dispensary are definitely not guilt-free, if that answers your question. Yeah, no problem.
Hello.
Hello.
So you mentioned that a lot of pharmacists are uncomfortable with counseling drug-to-drug interactions with cannabis and other drugs. I was wondering if there's any like courses or changes in curriculum for future pharmacists to educate them on this kind of material, just with the increasing popularity and the legalization in many states.
Yeah, no, that's a fantastic question and thought, and I think at some point it's going to have to be. I'm not sure if it's going to start as a full-blown course, but at least topics within your, pharmacology or medicinal chemistry courses or pharmacotherapeutics, et cetera, because we can't ignore it. I graduated U of A in 2015. We were number 7 when I applied, and I was number 5. That's pretty good. And we had an amazing curriculum, but we never really talked about it because it was still federally illegal and it really wasn't legalized in many states. And so, we're looking at prescription medications, and so it doesn't really come up. And I think that's exactly why you see a lot of pharmacists today who are uncomfortable with this because they didn't have that traditional didactic exposure. And if you look in micromedics, because there is not a pure cannabis profile in micromedics, because it's not an FDA-approved drug as the natural product, there's not there. You kind of have to piecemeal your way again through Nabilone or Dronabinol, and then we have products from other countries like Sativex, which has combinations, which you can say, okay, let's take the literature from outside the U.S. and try to apply it here. So you're kind of piecemealing your way together, but we don't have the answers and the resources that we're used to looking at, and I think that's a big issue that we will have to address both at the didactic standpoint while we're in school, but more immediately now as we are practicing professionals and the experts to respond to a need here.
And that's it?
Okay.
So I want to thank everybody for coming today. As you heard from the beginning, this is our first time doing something like this. I hope you enjoyed it. I hope you learned something. We'll continue to this, and thank you.
Please scan the QR code, give us some feedback, and then you can also choose future topics. Thank you.